Welcome to another video from My Hematology, where we make hematology simple. Today, we will be exploring the topic of vitamin B12 or cobalamin deficiency. Before we dive deeper into vitamin B12 deficiency, cobalamin deficiency is classified under the nutritional anemia and is known as a type of megaloblastic anemia. So, what is megaloblastic anemia? Megaloblastic anemia is defined as a type of anemia caused by defective DNA synthesis due to vitamin B12 or folate deficiency. This causes delayed red cell nucleus maturation or ineffective hematopoiesis in the bone marrow, leading to macrocytic red cells and others. Hematopoiesis is the production of blood cells which depends on an orderly cell division and differentiation for expansion and maturation of progenitor cells into members of circulating blood cells. For this to happen, vitamin B12 and folate is needed for the nucleic acid or DNA formation. Insufficient vitamin B12 or folate in the body will lead to megaloblastic anemia, in which the DNA synthesis is impaired, resulting in slowing or arrest of cellular division during the DNA synthesis phase of the cell cycle, which is the S phase. A high percentage of defective cells undergo apoptosis, leading to ineffective erythropoiesis. However, RNA synthesis and cytoplasmic differentiation are relatively unaffected. Thus, surviving progenitors and progeny are enlarged or have the appearance of macrocytic cells, which results in macrocytic or large red blood cells, hypersegmented neutrophils, and thrombocytopenia. As this is a nutritional disorder, vitamin B12 is found in foods of animal origin such as liver, meat, fish, and dairy products, but not in fruit, cereals, or vegetables. Let's take a deeper look into the vitamin B12 physiology. Following ingestion, some cobalamin or vitamin B12 in food is transferred to the human hepatocorrin and saliva. The acidic environment of the stomach enables efficient release and transfer of the remaining food cobalamin to hepatocorrin in gastric juice. After transit to the duodenum, increase in pH enables the transfer of cobalamin from hepatocorrin to intrinsic factor, a transport protein secreted by gastric parietal cells. The cobalamin intrinsic factor complex resists digestion and travels down the gut until it encounters epithelial cells in the distal ileum that express cubilin, a specific receptor for this biomolecular complex. The cobalamin that is absorbed in the ileum exits the basolateral side of the mucosal epithelial cell and enters the blood and binds to transcobalamin, which it will then travel via the portal circulation to the liver. Circulating transcobalamin cobalamin complexes then bind and are taken up into cells by transcobalamin receptors. B12 is needed in the conversion of methyl tetrahydrofolate to THF, a reaction in which homocysteine is methylated to methionine. During another reaction involving the conversion of amino acid serine to glycine, a methyl group is transferred to THF to form the N510 methylene THF, which is required for both de novo purine biosynthesis and for the conversion of deoxyuridylate to deoxytimidylate. Thus, cobalamin and folate both play critical roles in the production of the building blocks of DNA. In Western countries, severe deficiency of vitamin B12 is usually caused by pernicious anemia, while less common causes are intestinal malabsorption like Crohn's disease, veganism, gastrectomy, or small intestinal lesions, fish tapeworm infestation, and others. Pernicious anemia is an autoimmune disorder due to the destruction of gastric parietal cells. Parietal cells are the source of intrinsic factors and are also responsible for pumping hydrochloric acid into gastric lumen. It is believed that the autoimmune attack is initiated by gastric dendritic cells, which helps to clear apoptotic parietal cells produced during the normal turnover of gastric mucosa. These dendritic cells migrate to the paragastric lymph nodes where they present peptides derived from the proton potassium ATPase on the parietal cells to autoreactive CD4 plus T lymphocytes. And then these T lymphocytes would then attack the parietal cells. Over 90% of the patients also have serum antibodies against parietal cells, and about 50% have antibodies against intrinsic factors. General features of anemia can be presented initially like lethargy and mild jaundice. In more severe cases, some patients develop angular stomatitis, a sore, beefy, red, smooth tongue due to atrophy of the papillae, sterility, or fetal neural tube defects. However, neurologic manifestations are seen in cobalamin deficiency. Most patients complain of numbness or tingling, generally in the legs. In laboratory investigations, there will be a general reduction in all blood cells production, and the red blood cells are macrocytic. The peripheral blood smear reveals anisocytosis and macroovalocytes with hypersegmented neutrophil, which is an important indicator of megaloblastic anemia. Specific tests for B12 deficiency will reveal decreased serum B12 level with increased serum methylmalonic acid and homocysteine levels. Specific tests to diagnose pernicious anemia includes Schilling's test. The patient is given radioactively tagged oral doses of vitamin B12 and their 24-hour urine level of cobalamin is studied. The patient can also be tested for autoantibodies to intrinsic factors with an immunoassay or have their level of intrinsic factor evaluated. For treatment purposes, patients with cobalamin deficiency, hydroxycobalamin can be given orally or intramuscularly. Most cases only need therapy with the appropriate vitamin. Before we wrap up, let's go over the key points of vitamin B12 or cobalamin deficiency again. The common signs and symptoms of vitamin B12 deficiency include features of anemia like lethargy and shortness of breath, glossitis, angular stomatitis, neural tube defects, and specific to cobalamin deficiency, we can see tingling in the feet, difficulty in gait, visual or psychiatric disorders in severe cases. Causes of vitamin B12 deficiency includes intrinsic factor deficiency, which can be caused by pernicious anemia, malabsorption, or the dietary. Laboratory diagnosis of vitamin B12 deficiency includes a decrease in hemoglobin level and increase in MCV, and the peripheral blood smear will reveal ovalomacrocytes, anisopoikilocytosis, and hypersegmented neutrophils, while specific tests includes a decrease in serum B12 level and increase in serum methylmalonic acid and homocysteine. While specific to pernicious anemia, we can see a decrease in intrinsic factor levels, or there's an intrinsic factor antibodies or an abnormal Schilling's test. The treatment and management of vitamin B12 deficiency is hydroxycobalamin. If you like this video, click like and subscribe for more videos. And thanks for watching.